This is a story about a patient who did not listen to her doctor, and she was right. Her doctor made a recommendation for monitoring of her breast lesion, but she chose to have a biopsy twice over. This provides us with some insight and information, but please note that it is not a substitute for a medical consult, and individual outcomes after treatment may vary. With that understanding, let's review this patient's journey from screening to breast cancer diagnosis together. Shall we? Knowing that early detection of breast cancer can potentially save her life, Nora Zila, or Ra as a short pseudonym, commenced participation in a screening program soon after she turned 40 years old. When she was 47 years old, this ultrasound examination performed as part of screening detected a finding in her breast. Compared to the previous examination, it appeared to be slightly larger. Detection through screening usually means that the finding cannot be felt, or what doctors would term as impalpable. This would still be true if it were noted to be slightly larger while being monitored. Ra's finding appeared as a darker area compared to the surrounding breast tissue, and doctors would refer to it as hypoechoic. In medical terms, Ra had an impalpable hypoechoic lesion. Her doctor recommended that her lesion be monitored in 6 months with a repeat ultrasound examination, as the assessment was that the lesion had a 99% chance of being not cancer. How did the doctor come to this conclusion? Briefly, textbooks and prominent experts in the field teach that these are benign features when an ultrasound examination identifies a lesion in the breast. An ellipsoid shape, which is wider than tall, and a thin echogenic capsule are deemed to be characteristics of benign lesions. This is a picture of what a benign lesion is expected to look like on ultrasound, and this is the lesion that was identified in Ra's right breast. If it is so similar, why did Ra's doctor not give her the full assurance that the condition was benign? Well, it is important to be aware that imaging cannot provide us with a definitive diagnosis of what type of change has occurred within the breast. With ultrasound, while it is possible to differentiate a lesion which is probably benign from that which is likely to be cancer, we cannot be certain based on an ultrasound image alone. It is only when tissue associated with the ultrasound finding has been removed and sent for microscopic or pathology examination that we can come to a diagnosis. Under the microscope, based on the patterns the cells form, pathologists will be able to tell if the lesion is associated with normal tissue or benign breast changes and differentiate it from cancer change. Invasive ductal carcinoma is the medical term for one form of breast cancer. There are many pathologic conditions of the breast, and here is an abbreviated list. For a full list, you may wish to refer to a text like a book that is edited by a well-known pathologist, Professor Rosen. So when a lesion is detected in the breast through an ultrasound examination, and it has benign or probably benign characteristics, studies have shown that it has between a 0.2 to 2% chance of being cancer. Let's look at 2 of these studies. In her review of 4 studies, a prominent radiologist in the United States stated that for findings that were classified as benign or probably benign, 1 in 605 lesions, or 0.2%, were diagnosed as malignant. This is consistent with another study from South Korea, where it was noted that there were 22 cancers detected out of 19,435 ultrasound examinations. In order to avoid a biopsy for 19,413 women, whose findings eventually turned out to be benign, monitoring such lesions are usually recommended. Avoiding biopsy also means preventing possible complications which may result from the procedure. For this reason, the concept of monitoring probably benign lesions has been long advocated for lesions that carry a less than 2% likelihood of malignancy. It is thought that performing surveillance of probably benign findings is appropriate, as these lesions demonstrate increase very rarely, and those few lesions later found to be malignant are still early-stage cancers. Moving back to this study by a team of Korean doctors, we will recall that of 19,435 ultrasound examinations, 214 lesions were found to have increased in size. Biopsy was performed for these 214 lesions, and 22 were found to be malignant. There was a slight increase in the size of Ra's lesion, but this was not rapid enough to classify it as having a likelihood of malignancy greater than 2%. Therefore, monitoring was suggested, as there is a very small but real risk of complications with breast biopsy. Our patient Ra, however, decided that she wanted to undergo a biopsy to have certainty of her diagnosis. After her biopsy, the pathologic diagnosis of this ultrasound lesion in Ra's right breast was reported as fibrocystic change. No malignancy was seen in spite of the slight increase in size. In summary, the lesion was not cancer, and she was among the 99% of women who did not need to have undergone a biopsy and subject themselves to the possibility of procedural complications. So was she right to have requested a biopsy against her doctor's advice, which was to monitor the lesion and review it in a few months? We'll address that later in the video. Let us continue with Ra's journey. The biopsy for the lesion in her right breast resulted in its complete removal and a tiny scar on the skin. This was evident on an ultrasound examination done a few months after her first biopsy. Similarly, in the following year, there were no ultrasound findings detected in both her breasts. She skipped her screening appointment the next year. However, when she returned for a screening evaluation at age 50, ultrasound examination detected a new finding in her left breast. This was once again reported as probably benign. As you can see, the appearance of this lesion was not too different from what is taught about the characteristics of probably benign lesions. At the review of the mammogram and ultrasound findings, Ra's doctor took note of the new left breast nodule and assessed it to have a 0.2% risk of being not benign. In other words, she had a 0.2% chance of having cancer. Based on this assessment, her doctor recommended that she should return in about 9 months for follow-up. However, Ra expressed her wish to have a biopsy. As with the previous time, she underwent a vacuum-assisted breast biopsy of the new lesion. As it was also impalpable, or too small to be felt, the procedure had to be guided by ultrasound to identify the position of the nodule. At the end of the procedure, the ultrasound image of the new finding was removed. This time, pathology examination of the tissue cores removed from Ra's left breast were found to contain invasive ductal carcinoma. So after her second biopsy, Ra was found to have cancer in the left breast. She was among the 0.2% of women who had lesions with probably benign ultrasound characteristics, but actually harbored breast cancer on pathology. Ra underwent a further surgical procedure and successfully achieved breast conservation. I am happy to report that she completed all phases of her treatment and her therapy went well. I know that many women will now ask if they should undergo a biopsy every time a lesion is detected. Please discuss this with your doctor because every situation is unique. I would say Ra's circumstances were unique. She had one lesion detected on ultrasound at age 47 and one lesion detected at age 50. A vacuum biopsy to remove the lesions, as she underwent each time, takes about 15 to 20 minutes and carries about a 0.2% risk of complications. Removing one lesion at a time can be achieved without too much difficulty. However, there are women who have multiple lesions in the breast, and it would be impractical to remove them all, because depending on the nature of the pathologic change, some lesions may resolve with time. Also, new additional lesions may emerge in the future as a woman continues screening examinations. In a screening context, if this patient with 61 lesions chose to remove every single lesion, it would take hours and she would concomitantly increase her complication risk by 61 times. Furthermore, even if the removal of all the lesions were performed uneventfully, she may develop new findings in future. So, in summary, I do not think it is a practical solution to remove every single lesion that is detected by ultrasound. If the features are consistent with probably benign lesions, in general, your doctor would recommend monitoring. However, should you have specific concerns, do discuss them with your doctor, and you can make an appeal to have a biopsy done, just as Ra did. Bear in mind that there are also issues that you may have to work out with your healthcare insurance company, as they may not reimburse the cost of a biopsy procedure for a probably benign lesion, especially if it turns out to be benign on pathology. I hope that the information here has been helpful for understanding how doctors manage probably benign lesions detected on ultrasound screening. The first recommendation would be to monitor the behavior of the lesion for any change in appearance and size. I encourage you to discuss your findings and options with your doctor before coming to a decision. Needless to say, you must be comfortable with the decision about your clinical management plan. If you have found this useful, please like, share, comment, and subscribe. You may also wish to visit the Just Medicine website through the link in the description below for more information. You can also make a personal request for supporting data on conditions of the breast. Thank you so much for staying until the end of this video. I wish you all the very best for your breast health. Cheers.